Hi everyone, welcome to Research MD. We've been doing series of morning reports for all of us to learn. So today we're going to start our morning report session. Okay, so tell me about today's presenting complaint.
Yes, it was a 27-year-old Asian male who presented with intermittent diarrhea, abdominal bloating.
27-year-old Asian male
with intermittent diarrhea, abdominal bloating.
Okay, so we got diarrhea.
Yes,
right?
for the past 5 years.
Okay, so anytime, I have told everyone before, right? The first thing is like we need to make sure there's no emergency we could miss, right? Because if you take your own sweet 2-3 hours long H&P and then you come with a diagnosis, you lose a lot of valuable time. So when you look about diarrhea, I don't see that much a big emergency we could miss in here, right? Only the patient become like really, of course, like patient is severe diarrhea and maybe hypotensive, and then that's a big issue. I'm not saying that. But when you talk about diarrhea, right, we need to classify diarrhea. So somebody tell me the classification. What is, is this like an acute, this is like an intermittent, or I need to know this is a chronic diarrhea. So somebody tell me, I'm going to ask each person, what is acute diarrhea definition? Express in numbers. If you cannot express in numbers, that means you don't know. So what is acute diarrhea?
3 episodes per day.
That is a definition of diarrhea, right? You can say that 3 episodes per day, or you can say like 200 milligram in 24 hours, 200 ml greater than 24 hours. That's a definition of diarrhea. But what is acute diarrhea? What is chronic diarrhea? What is intermittent diarrhea? Somebody need to tell me.
Acute would be less than 2 weeks.
Yeah, 14 days.
14 days.
Okay. And then intermittent?
Intermittent from 14 days till
to 30 days.
30 days.
Okay, and the chronic diarrhea?
More than 1 month.
More than 1 month. So in this patient, what does he have diarrhea for? How long does he have?
For the past 5 years.
Past 5 years,
yes.
We've been having diarrhea. So this is a chronic diarrhea, we would say,
yes.
right? It's greater than 30. That's very important. Okay.
Yes.
So when somebody have diarrhea, let's look at our differential diagnosis first, and we will come back to it. Okay. So what is the first thing I would do is like we know this is like a chronic diarrhea, right?
Yes.
We all agree that. This is like 5 years has been going on, right?
Yes.
And then I would do like the first step is always to find out, this patient have fecal incontinence. Okay? That's the number one thing to do. When anybody have like diarrhea, we have to do. Why is that? Fecal incontinence. Why is it like this? People is going to come to you and said, I got fecal incontinence? No. It's like an embarrassing situation for the patients, right? So they're always trying to hide it. And they say like, I've been having diarrhea. So you need to ask questions like all of this, right? And then the other thing I will do is make sure there is no fecal impaction. Okay?
Yes.
And the next thing I do is like, I look at the medications, right?
Yeah.
So what are the common some of the medication? Like any medication pretty much can cause it. Like what are the most common kind of thing you can say like the medication? Metformin, yeah, if the patient is on, and diabetes is very important. Metformin, what else? Any kind of antibiotic, right? That can cause it. NSAID itself, right? A lot of people take it for pain medicine, so NSAID can cause it. What else?
SSRIs?
SSRI is also a big one. So we know all of this. So, and then like once I know that, right? So I will, if all of this kind of rule out, then I look at the other differential diagnosis, like is it inflammatory diarrhea, right? And then I look at is it fatty diarrhea or watery diarrhea in the classification. Okay? So let's look at that. Now I put it up here. First one is like inflammatory diarrhea. Okay? And then we'll talk about fatty, right? And then we can see like a broad classification. So somebody tell me like what are the inflammatory causes of diarrhea? Somebody tell me.
Crohn's?
Yeah, very common, inflammatory bowel disease, right? Let's say like IBD, right? Yeah. This is like a real inflammation. What are the other like bacterial causes or viral, those kind of things can also cause it. Somebody said like some of the causes. CMV, yep. What else?
TB, C. diff,
HIV, when we talk about HIV, we'll come back. It's more like an opportunistic organism. HIV could itself causes, because it can affect any part of the system also. Okay, so we talk about this inflammatory diarrhea. We looked at the causes and all that, right? We talk about inflammation and some infectious causes also will be in there. And then what is the next thing we have to talk about? What is that? Fatty diarrhea, right? What are the main causes of like fatty diarrhea?
Pancreatic insufficiency.
Very good. Say like pancreatic deficiency, insufficiency. What else?
Celiac disease.
Celiac disease. What else?
Fatty diarrhea. Giardia.
Giardia. Okay, very good. Okay. What else? What else could be some of the causes?
It can be bile acid.
Bacterial overgrowth,
Yes.
right? Small intestine. What is it called? SIBO.
Yes.
Right? That could be like one of the reasons, could be like, very common reason. Celiac disease, we talk about pancreatic, any kind of maldigestion or malabsorption, right? Maldigestion, malabsorption. Maldigestion. Okay, so that is like usually the fatty diarrhea, right? And then what are the things we have to talk about, like watery diarrhea, okay? What is the first thing we have to do is like, we need to know is like secretory diarrhea or osmotic diarrhea. So what do we have to do? Somebody tell me what is the first thing we have to do, right? We need to do some fasting and see the diarrhea. Anytime it's like a watery diarrhea, the first thing I do is like look at, make sure the fasting, what happened in the effect of the fasting. So what happened in the fasting with the osmotic diarrhea?
The volume is decreased.
Volume. If the volume decreased, volume is what?
It's osmotic diarrhea.
It's osmotic diarrhea. And what happened over here?
If the volume is same, then it's secretory diarrhea. Secretory diarrhea.
Secretory, right? So very important to do the fasting to find out this is secretory diarrhea or like osmotic diarrhea. Okay. Next thing we have to do is check the stool osmotic gap. Okay. Stool osmotic gap. So first thing we do is we find out, what is a plasma osmolarity take? What is a normal plasma osmolarity? Somebody said that?
290.
That's a 290. And then minus, you take 2 times sodium plus potassium. Okay. Now, if it is, we have to put, if it is greater than 50, okay, so what does that mean? If this, you calculate the osmotic gap, let's start with like less than 50. What are the causes in that? If it is less than 50, somebody tell me that.
Secretory causes.
Okay, secretory causes, very good. Okay, and if it is greater than 50?
Osmotic.
Osmotic causes. Okay, did everybody got that? Now we look at the causes. What are the secretory causes? Let's say, what are some of the secretory causes? Somebody tell me. Carcinoid, another one, right?
Yes.
Any kind of like hormone secreting. Let's put that. Hormone secreting. Is it okay? If I put hormone secreting. Okay.
Carcinoid.
What else?
Doctor, could we even have VIPomas?
VIPoma, very good.
Glucagonoma, insulinoma.
VIPoma, what else?
Glucagonoma.
Carcinoid, right?
Yeah.
And then?
Medications.
Medications kind of comes into play.
Bile acid.
Anything else do we miss?
Bile acid diarrhea.
Microscopic colitis, so
Yes.
that is the other board. Like if you're writing an examination question, they can write that microscopic colitis. Okay, remember that. Microscopic colitis. What else? That's okay.
Yes.
And then now let's look at the osmotic causes. Let's say the osmotic gap is greater than 50. Some of the causes like osmotic causes, right? And the next thing what you have to do in that situation, I would do is I check the pH of the stool. Okay? So normal pH of the stool is around 6. Remember that. Some numbers we have to know. Okay? So what is that? Like if it is the pH is less than 6, and we need to know there is is greater than 6. Okay? Let's do that. Now, next thing we look at is the pH is less than 6 or greater than 6. Everybody got that? Once we know this osmotic, greater than 50, you look at the stool pH. You order the stool pH. If it is less than 6, what does that mean? It's mainly sugar. Can we say that?
Yes.
It's mainly sugar, let's say like sorbitol, right?
Yes.
And then lactose and all of this causing. If it is greater than 6, what does it tell us? Somebody said like increase irons maybe, right? Why is it important? This is where the magnesium containing, like, the diarrhea products and all that, anti-diarrhea medication, laxative, magnesium containing.
Phosphate.
Phosphate, okay, very good.
Sulfate.
Okay, so we got like all of this. That's like a basic kind of definition of the diarrhea. How do I investigate? That's the main thing I usually do. Everybody got that? Just look at the differential diagnosis one more time. Somebody with the diarrhea, the first thing I always kind of say is like, is there any emergencies kind of causing? If it's severely hypotensive, like that's where like you need to get a lot of fluid to bring him back. And then I put is it acute? Then I will say is chronic and intermittent. And then if it is like a chronic diarrhea, in this patient, the first thing I would do is what? I make sure the patient is not fecal incontinence or no fecal impaction on this patient, right? And the next thing I do usually check the medication list. What is going? Next thing I would do, like, if it is inflammatory diarrhea. When you talk about inflammatory diarrhea, we just say like inflammatory bowel disease kind of very common. Then we talk about the bacterial causes, maybe like Clostridium difficile infection, and then we talk about the CMV, the TB, and all of those kind of we talk about, right? Then we talk about once we do that, then we just kind of roll out these inflammatory causes. Then we put it in 2 different categories. Either there is like fatty and watery. Okay, remember that. When we talk about the fatty, then you can say pancreatic insufficiency, celiac disease, giardia, small intestinal bacterial overgrowth, malabsorption, maldigestion is the common. It's very important to know it's a huge chronic diarrhea kind of cause, okay? And then you have watery diarrhea. When you have if it is watery diarrhea, first thing I always do, check for fasting, and if it is improved with the fasting, right? If it is like decreased volume, then it's like osmotic diarrhea. It doesn't change secretory, and then I do the stool osmotic gas. The formula: plasma osmolarity minus 2 sodium, 2 times sodium plus potassium. And if it is greater than 50, I know this is osmotic diarrhea. Then I look at the stool pH. If it is less than 6, then I think about sugar, sorbitol, and lactose. And then if it is greater than 6, I look at the irons, like magnesium containing irons, okay? And then let's say if the osmotic gap is less than 50, then you have hormone secreting, you talk about like carcinoid, vipinoma, right? And medication, microscopic colitis. Those are the one this is the way I put it. And then there's like one more category we need to know, is it functional? Okay, usually like inflammatory bowel disease, the other, you can put it in the functional also. Okay, so don't forget the functional also. Somebody just kind of tell me what is the functional again one more time?
Irritable bowel syndrome.
Irritable bowel syndrome, IBS. Okay, remember that. And then there's also factitious, right? What do the people usually do when they're factitious? Like, what do they do?
They can add urine.
Yeah, they can do, urine at that time. Urine or what else? They usually kind of put like ketchup. Right?
Yes.
So in that situation, what we can do is like, you can check the stool osmolarity. Okay? And then if there is like, if the stool osmolarity is less than 290 or less than, then you have to think about what? They put water or urine in there. Okay? If it is greater than 600 or really high, then the patient might have added ketchup. In today's world, all of this is very common, but it's very important to think about differential diagnosis, okay? So now tell me about this case a little bit more.
Yes. So the patient mentioned he had these episodes several times per week.
Okay.
With mild cramping abdominal pain, which is followed by explosive watery bowel movements.
Okay, so we've been having watery diarrhea over here,
Yes.
okay.
With a large amount of flatus.
Okay.
The patient denies any blood in stool or fever, weight loss, anorexia, or fecal incontinence.
All right, now let's go into our past medical history, right? We're just going to put the past medical history. Why is it past medical history is important? lot of things we talk about, right? Inflammatory bowel disease, like, there's malignancy and all of those kind of things, like so many things can contribute it, like TB and all of that, okay? And then tell me about the past medical history in this
Past
patient.
medical history is not significant.
Nothing significant, okay. And then we talk about allergies. Why is it allergies important in this patient? What is it? What is gluten allergy? What is it kind of related to? Gluten allergy, celiac disease, right?
Yes.
Celiac disease. So you have to know allergy. And what about family history? Why do we need to know the family history?
IBD,
IBD, inflammatory
Yes.
bowel disease, celiac disease, and all this kind of thing. So it's important to get the family history also. Medications? What medicines the patient is on?
The patient just takes multivitamins, and that's all that he takes.
Okay, so we have to be careful, like vitamin C and all those kind of cause cause also diarrhea, right? Okay, what else? Social history. Why is it social history is important? Chronic alcohol, can it cause diarrhea?
Yeah.
What type of diarrhea does it cause?
Because
Secretory?
Secretory diarrhea. So we didn't write it up here. Secretory diarrhea, chronic alcohol, PTOH, okay?
Yeah.
And what about the sexual history? Do we need to know? Why is the sexual history important? HIV, right?
Yes.
Opportunistic infection, then cryptosporidium and all those kind of thing and all that. Is the travel history is important?
Yes.
Yeah.
Like amoeba and all of this can,
Yes.
it can a long time. Some of this kind of stay stay in the system because of the cyst formation and all that, right? What about psych history? Why is it important? Psych. Anytime fictitious diarrhea we talked about already, and then we talk about SSRI, right? If the patient is on SSRI. So tell me the vital signs.
Yes.
What is the patient vital
Blood
signs?
pressure is 130/90. Temperature was 96.7. Pulse 75. Pulse 75. Respiratory rate 14. And saturation was 98%.
98%. Okay, so the vital signs seems to be normal. We don't suspect any kind of not dehydration, could be hypotension, tachycardia, none of this kind of showing up. Maybe the body has adjusted. Diarrhea has been going on for a very long time, right? So what lab tests would you do in this patient? So tell me, you start with the CBC, right? We need to know infections going on and all that. What is the WBC in this patient?
8.4.
8.4, that was normal. What is the hemoglobin?
16.
Okay.
Platelets 152.
152. Okay. Now let's look at the our electrolyte. Sodium is important to us?
Yes.
Okay. Sodium is important because dehydration, hypovolemic hyponatremia is very common. What's sodium?
137.
Okay. Potassium?
Potassium 3.5.
Okay.
Chloride 98. Bicarb 29.
Okay.
Bun 17. Creatinine 0.6.
0.6. Okay, nothing significant,
Yes.
maybe a little bit of metabolic alkalosis. And then, okay, what else? What are the other studies we need to do?
We also did stool studies.
Okay, very good. So we did stool studies. What did we find in the stool studies? What are we looking for? We already said, right?
Yes.
Don't try to do too many things. What did we talk about? What's the first thing we said? Stool studies. What are we calculating for?
Stool
osmotic gap, right? You take the plasma osmolarity minus 2 times sodium plus potassium. So what do we do? So tell me, so we take the 290 minus, right? 2 times, and we need to know sodium. What is the stool sodium?
Sodium was 80.
80?
Yes.
Okay.
And potassium was 20.
Potassium was 20. Okay, so what do we have? Now we have to calculate. Somebody tell me what is the calculator right here.
90.
So 80 to plus 20 is 100. That's 200. So we got 90.
Yes.
Stool osmotic gap is what?
90.
Everybody got that?
Yes. We also did stool microscopy and culture.
Okay, let's stop right here. Okay, so we'll talk about 90. So what is that? Well, now we come up here. What do we have? Stool, increase osmotic gap. So we have to talk about osmotic diarrhea. So what's the next step we have to do? Do we do that? What is the stool pH?
Stool pH is 5.
Stool pH of 5. So what is the stuff? Now we have to talk about sugar, sorbitol, any lactose, right? Lactose dealer kind of problem right here. So what else? Any other studies?
We did stool microscopy and culture.
Yeah.
And the results were not significant.
Okay, nothing in stool culture was negative. Very good. So all of that negative. So now somebody tell me what's our diagnosis in this patient?
Osmotic diarrhea.
Definitely osmotic diarrhea. You can say that. Caused by what? And what is the most common? Somebody tell me what's the most common?
Lactose intolerance.
Lactose intolerance, right? So we just say like lactose intolerance. So it's very important because we know there is osmotic graph greater than 90. We know the stool pH is less than 6, so something kind of related to lactose intolerance, right? So most common we said lactose intolerance. Also, I would just say, going back up here, what is that? What is this? Can somebody say?
Yes,
It's very
Asian.
common in Asian, right?
Yes.
Lactose intolerance. So how do you treat it?
Avoid dairy
Avoid
products.
Avoid dairy products, supportive care, right?
Yep.
Supportive care, right?
Yeah.
Then I would just go back and find out. It's very important. Is going to go his diet history and those kind of things. Okay.
Yes.
So what happens? Like what happened when you take lactose? So it's very good to know what are the two things lactose is broken down into by lactase enzyme, right?
Yes.
Okay,
Yes.
what is that broken down to? Galactose and glucose. Okay, so it's broken down to galactose and glucose. Everybody remember that, right? So what happens if you don't have that? Let's say like if you have deficiency, it doesn't work. What happened? What happened next?
Fermentation.
Fermentation.
Bacterial fermentation, right?
By intestinal microbes.
Bacterial fermentation. And then what else? You got gas,
Yes.
right? Distension, all of this complications, diarrhea, right? All of this could happen. So it's important to know the pathophysiology a little bit, okay? So most likely this is an osmotic diarrhea. And then we think because of Asian, it's very common, lactose intolerance, we think that could be one of the reasons. Go back and check his history, and then mainly supportive care. And remember, the lactose is broken down by lactase into galactose and glucose, which does not happen in this case because of the deficiency. And you can have bacterial fermentation, gas, distension, diarrhea. So everybody got it, like how to at least have an understanding. It's a very long topic, but it's very important to know that. You will see patients like this in your clinic situation. Thank you so much for watching. We'll be back with another presentation. If you have any comments, let's have a discussion so we can learn from each other. Please put it under your comments. Thank you so much again. Please subscribe to our channel. Thank you.